All right, hi, it's Katie Wiskar from UBC. I am POCUS. This is another pathology slides video. So again, the goal of these videos is to show you some examples of normals, but also what abnormal looks like as you're learning, because often we learn these scans on normal. So it's a good idea to have an idea of what pathology looks like so that you can recognize it when you're scanning your patients. Today, we're talking about basic abdominal scanning, right upper quadrant, left upper quadrant pelvis, and the identification of free fluid. Okay, this is just a normal right upper quadrant. Well, not totally normal because we probably have a pleural effusion hanging out there above the diaphragm, given that black space. But we see a normal appearing kidney. We see a normal appearing liver. We see diaphragm. The potential space between kidney and liver, of course, is Morrison's pouch, and we don't see any free fluid there. This would be an example of free fluid. Ascites in this case, but if we didn't have any patient background, this could be other fluid. This could be blood, for example. So reminder that when we're scanning the abdomen, on the right side, there are three places that we want to see to look for free fluid. Those are our three most sensitive spots that we would scan as part of a FAST exam, for example. On the right, those spots are the hepatorenal interface, so Morrison's pouch, the inferior tip of the liver, and the inferior pole of the kidney, also called the pericolic gutter. So here you can see within this clip, we sort of see the inferior pole of the kidney right at the start. We see the hepatorenal interface and there's clearly fluid there. And then we also see the tip of the liver and there's fluid collected around there as well. Here's another example. So we're still on the right side. You note that we've labeled this as right upper quadrant. It's a good idea to label your abdominal scans if it's not obvious where you are, because right and left can look somewhat similar. So in the right upper quadrant, we're seeing Morrison's pouch, so the hepatorenal interface, and this is a good example of what trace fluid would look like. So if we're talking about ascites and a paracentesis, obviously this is not fluid we would go after. But in a different context, for example, a trauma patient, and you're worried about intra-abdominal bleeding, this could certainly be significant here, this trace black fluid. This is just another nice example of ascites. Here we seem to be on the left side. We don't see any intra-abdominal organ here, but we see soft tissue, and then we see loops of bowel floating around in our ascites. As a reminder, when we're looking for free fluid, we should note a couple of things. So free fluid in the abdomen should not look encapsulated. It shouldn't look rounded or have a geometric shape. It should fill irregular spaces, so all these little nooks and crannies between these loops of bowel. It should move. We should see kind of bowel structures moving within it. That's all reassuring for this truly being free fluid, and in this case, ascites. We'll see some examples later on where the fluid looks much more encapsulated and rounded, and that's always concerning for this not truly being free fluid or ascites, but being something like a large cyst, for example. This is just an impressive example of a spleen. So you can see here we're in the left upper quadrant, or left lower quadrant, because we've gone down so far because of this big spleen. But we can see kidney that we're fanning through. As we fan through, we see some spine under kidney. And then we see our very large spleen. We don't even have it all in view at this point. So you can, if you want to try to get all of your spleen in view, you can measure kind of lengthways across your spleen to get an idea. Though this is kind of a bonus with POCUS, it's not something we habitually do to measure our intra-abdominal organs. Also, as a note, you see that we're fanning in this clip. We're kind of fanning through the image. And it's perfectly acceptable to fan through our images in the abdomen. The general rule in POCUS is that if the object of interest is moving, so the heart, for example, or the lungs, then you should stay still. If the object of interest is stationary, then it's acceptable to kind of slowly fan to survey the entire area, as we're doing here. This is an interesting example. So I'm not sure what side we're on because we're not labeled, but it looks as though there's some intra-abdominal organ on screen left there. And we see two kind of black areas, anechoic or hypoechoic areas. One that's deeper here that looks very rounded, that I would say is certainly not free fluid. Knowing this case, I can tell you it's a pancreatic pseudocyst, but if I didn't know that, I would just say it's some sort of fluid-filled cystic or potentially even an aneurysm, some sort of collection filled with dark anechoic fluid. And then the anechoic kind of black area that's more superficial has a lot of stranding to it, right? So it's not simple and black. There's a lot of kind of fibrant stranding. There's these isoechoic gray areas. So in this case, this was complex ascites, really suspicious for kind of complicated ascites, something that's long-standing, maybe associated with complex pancreatitis in this case. But if I didn't know that, I would want to make sure I had some additional imaging, just because even that collection at the top there does look somewhat rounded and encapsulated. I don't see any bowel within it. So I would want to be really sure before poking something like that with a needle. This is kind of a cool clip. So small bowel obstruction is something that we don't see that often, but when you do see it with ultrasound, it's quite obvious. So normally ultrasound beams don't travel well through bowel. If you place the probe on kind of the right flank or the left flank or the midline, you'll see just kind of gray scatter. And that's because normally when there's a small amount of air in the bowel, which is normal, that will scatter your ultrasound beams and you won't actually see the structures underlying. However, when the bowel loops are filled with fluid, as they are in the case of small bowel obstruction, then we actually see the nicely outlined bowel loops. We see them filled with this dark black anechoic fluid. And you can actually see a little bit of to and fro movement here of the material within the bowel. And that is pathognomonic for small bowel obstruction, that to and fro peristalsis. Sometimes in normal situations, we will see a bowel loop with a little bit of peristalsis, but the fluid should only be going in one direction. That back and forth is indicative of an obstruction. We can also measure the bowel loops. We haven't done it here, but typically the cutoff is more than 3 centimeters, signifies dilated loops, again, consistent with an obstruction. Here we're in the right upper quadrant. We see nice kidney that we're fanning through. We see some aorta hanging out under there as we come through our image. And the thing to point out here is a small amount of black anechoic fluid right at the liver tip. So on the right side, the liver tip is the most sensitive area for identifying free fluid, which is why we always want to make sure we're visualizing it. Again, if we were worried about doing it, we were thinking about doing a paracentesis, this isn't necessarily a pocket of fluid I would go after because it's very small, but it certainly is there. This is just another nice example of some ascites. We have a little bit of what I think is liver tip in view there on screen left. And we see the bowel kind of floating in this ascites. We see the ascites making irregular shapes around those loops of bowel. So this is reassuring for this being free fluid again. And you could probably optimize this pocket so that it would be accessible for paracentesis. Certainly, we have enough fluid there at the top. This is an example of something that I would not poke, especially that larger pocket in the middle there. So we can see there's a few areas of black or anechoic kind of areas in our picture here. There's some anechoic fluid at the top of the screen that probably is ascites. But as we move down the screen, we see these kind of rounded encapsulated areas that are concerning and certainly don't look like free-flowing fluid. They could be highly complex cysts. In this case, this is a patient with polycystic kidney disease. So again, ascites shouldn't be rounded, geometric, encapsulated. That's the take-home point here. This is an example of ascites that is free-flowing, but again looks quite unusual because we have a lot of complexity. So instead of looking black and anechoic, the ascites looks quite gray. There's a lot of stuff floating around in there. You could even maybe call this a plankton sign. We sometimes see kind of swirling debris. So this would be suspicious for complex ascites. In this case, this was mucinous ascites, suggestive of a pathology probably other than straightforward cirrhosis, for example. This is another example of some bowel. So here we are seeing the loops of bowel. These are these kind of gray things because they are filled with feculent material, with fluid. Again, if there was air within these loops of bowel, we would just get shadowing the way we get A lines in the lungs, for example. And you can see some kind of peristaltic motion going through that bowel. And then we can see around the loops of bowel little bits of free fluid. So these little kind of pockets of black, that's small amounts of free fluid around these loops of bowel that are quite full of bowel material. This is just another nice normal, so beautiful kidney there. Very nice liver. We're fanning through. We see a little bit of diaphragm there on the edge of our screen. We see some hepatic veins as we're fanning through the liver. So again, we're using the curvilinear probe on the abdo setting. The ribs are always going to be there, and you can do your best to kind of get around them with some rotation of your probe sometimes a bit of sliding up or down. Can help you visualize the structures of interest. This is another example of bowel. So over on screen left there, you see just kind of gray fuzz. So that's what bowel looks like if there's a small amount of air in it. Your ultrasound beam just doesn't penetrate at all and you can't see anything. In contrast, over on screen right, we can sort of see this bowel filled with isoechoic dense stuff. It almost looks like the same echo texture as the liver or the spleen. So this is a fairly dilated loop of bowel full of fecal material. So this, in the right clinical context, could be supportive of severe constipation, for example, given that it doesn't look like fluid that's in that bowel loop. It's not black. It's more isoechoic than that. It's looking more solid. This is another nice dilated loop of bowel. This one looking like the bowel itself is more full of fluid, partly because we see that movement within it and partly because it's more anechoic or black. This is small bowel. That we're seeing here. And then around it, we're seeing some free fluid as well. And note that free fluid, again, is filling all these little irregular spaces around the loop of bowel, suggesting that truly is free-flowing fluid and not just another loop of bowel that I'm partially seeing. Here we are in the left upper quadrant. So we mentioned the 3 spots that you want to look for fluid on the right side as being the hepatorenal interface, the inferior pole of the right kidney, and the inferior tip of the liver. On the left side, our 3 spots are the inferior pole of the left kidney, the splenorenal interface, and then above the spleen. So on the left, fluid particularly likes to hide above the spleen, so between spleen and diaphragm, as we're seeing here. So we can see spleen, and then we can see diaphragm, and if you look closely, the fluid is actually underneath the diaphragm, just between spleen and diaphragm. So it can be sometimes tempting to call this a pleural effusion, for example, but it's not. That's why we really want to visualize that diaphragm and visualize what's going on in the lung as well. We actually, as the patient breathes in this clip, can see some lung curtaining in with what looks like a little A-line there. So this is not pleural fluid. This is intra-abdominal fluid or ascites. This is quite a dark image, a little bit difficult to see, but essentially we've got a normal spleen and a normal kidney with a normal kind of splenorenal interface as we're fanning in and out. We also see diaphragm there. We don't see any fluid in between the spleen and diaphragm. Another nice example of some fluid at the liver tip. Again, a common place for fluid to hide on the right, the most sensitive place for fluid on the right side. We also see a kidney here, and you'll note that the kidney looks quite bright, quite hyperechoic. And you may see this in ultrasound reports on your patients when they report kind of a bright echogenic kidney consistent with medical renal disease. So your patient with CKD will probably have a small, bright kidney that looks somewhat similar to this. This is another example of something that is not ascites. So you have these circles of black, which should always, again, be a flag that this is not free fluid. In this case, it's hard to see that there's actually underlying kidney here because so much of the renal architecture has been destroyed, but this is polycystic kidney disease. Again, the take-home point is not necessarily knowing how to identify this precisely with ultrasound, but knowing that these pockets of black are not ascites, and please don't poke these. This again is a nice example of intra-abdominal fluid rather than pleural fluid. And it can be sometimes hard to make that distinction. The caption says that we're on the right and calls this liver, although I think we might actually be on the left because we're labeled as L4. Again, a reminder to label your clips. But we see a small intra-abdominal organ. We can see lung and sort of A lines with a couple B lines curtaining over as the patient breathes. And then kind of at the end of the clip, we see diaphragm that allows us to say that this fluid looks like it's actually underneath the diaphragm, not above. So this is intra-abdominal fluid, ascites, not pleural fluid. So again, really, really key to see your diaphragm, see the intra-abdominal organ, see what's going on in the lung so that you can properly identify where this fluid is. Again, a really nice example of a little bit of ascites by the liver tip. We see some floating bowel loops within that. We see the soft tissues in the near field. And if you're going to plan for a procedure, for example, sometimes it can be quite nice to measure the soft tissues. And there's other tips for POCUS for procedures that we're not really going to get into today. But this is a nice little example of some ascites. Here's another example of a little bit of ascites, some bowel loops in there. And then the thing to point out here is the soft tissue is quite thick. You can see from the measurement on the side that we're almost at 4 centimeters with our soft tissue. And this is a patient that had a lot of anasarca, so a lot of kind of fluid within their soft tissues. And kind of 2 things to note there. One is that it makes the rest of our picture a bit less crisp and less defined because there's some attenuation of the ultrasound beams as it travels through that very thick soft tissue. So the rest of our picture doesn't look as nice and crisp. And then also obviously to note if you're planning a procedure, the larger the greater the soft tissue, the potentially more complicated it can be. You may need a longer needle. It can be a little more challenging. So sometimes it's worth scanning around and trying to find an area where the soft tissues are thinner, where there is less anasarca. So sometimes that means coming up from the flanks. So going away from the really dependent zones, coming a little bit more towards midline to find an area where the soft tissues are thinner to facilitate your procedure. Here's some more ascites or free fluid. We're in the right upper quadrant. There's a rib shadow kind of in the middle of our screen, inevitably. And the thing to point out here is that this liver looks quite cirrhotic. So again, you'll often see on ultrasound reports in your patient that the liver is described as nodular and small, and that's consistent with cirrhosis. So this isn't something we usually call on POCUS alone, but it's definitely something you will notice, especially if you're scanning your cirrhotic patients for ascites, for example. This is another spleen. I think we've seen this spleen actually already before, but just a normal splenorenal interface, but a very large spleen here. And note that spleen is that nice homogeneous echo texture. It's all the same. If you're looking for spleen and you see some of it that it's that nice kind of homogeneous gray and some of it that looks brighter and a bit more heterogeneous, you're probably seeing some bowel or some stomach in your view. And the move there is to fan or slide your beam more posteriorly so you can visualize all of spleen. This is an example, speaking of which, where we are looking for spleen and we are too far anterior. So we can see a little bit of lung and pleural line kind of on the left side of our screen there. We see a little bit of diaphragm, and then instead of seeing spleen, we see this kind of circular, very anechoic area. You might be tempted to call it spleen, but it doesn't have the typical appearance, and we don't see any kidney beside it, which we should normally see. So this is, and we see some little bubbles kind of going on in there within that anechoic space. So this is actually a big dilated stomach, which we can occasionally see in patients with small bowel obstruction or significant gastric distension. The spleen should look more isoechoic, more gray, more homogeneous, and we should see a splenorenal interface, so a kidney beside it. So if you're ever not sure what you're seeing on ultrasound, if it doesn't look quite usual, come back to kind of first principles and look for your other landmarks. Say, okay, if this is spleen, then kidney should be right here and spine should be underneath it. And if you don't see that, then it's probably something unusual that's going on. This is an image, again, demonstrating some free fluid between the diaphragm and the intra-abdominal organ. We're on the right side here, and you can see some lung and pleural line curtaining over as the patient breathes. We see liver. And then we see black. And the point to emphasize again here is that finding diaphragm is really key because that allows us to correctly identify this fluid as being beneath the diaphragm, so ascites, rather than above the diaphragm and pleural effusion. All right, that's everything. Again, these are just a little primer to give you an example of what some pathology looks like when you go out and scan your patients. Thanks.